University of Florida from 2016. So, right?
Sure.
He's a professor and director of musculoskeletal research at the DCRI, and he's the vice chair of clinical research in orthopedic surgery. His primary research interest involves biopsychosocial models for the prevention and treatment of chronic musculoskeletal pain disorders. There's a lot of syllables.
Yeah.
Next, we'll be hearing from Dr. Chad Cook, who's a professor here at Duke and directs the Doctor of Physical Therapy program. He has a BS in Physical Therapy from Maryville, and his PhD is from Texas Tech. He's authored over 200 peer-reviewed publications and has won numerous teaching awards at Duke, and has also served as the editor-in-chief and or associate and special topics editor for multiple journals. And finally, we'll be hearing from Dr. Adam Goode, who's associate professor in the Department of Orthopedic Surgery and a member of the DCRI in the Musculoskeletal Therapeutic area. He earned his Doctor of Physical Therapy degree from Duke and PhD in Epidemiology from University of North Carolina in Chapel Hill. So today is a good day for you, I imagine, not for the Blue Devils in the audience. His research focuses on the etiology of lumbar spine osteoarthritis and health services interventions related to physical therapy in primary care. Please join me in welcoming today's speakers.
Thank you. Does this automatically go off mute?
Should be, yeah.
Okay. Yeah. And then the slides, I know how to advance them. There we go. So thank you for the kind introduction. It's great to be here. It's funny when you mentioned biopsychosocial. So when I first started my research career, that was kind of like no one knew what that meant. It's a jargon term. Now it's a jargon term that you see in RFAs and people like to use it. So in another 10 years, it'll be trite and passé. So it'll be nice to see the life cycle of that term. But thank you for having us. We look forward to kind of introducing what this therapeutic area might be about and giving some research examples of things that are ongoing, planned, and completed. So it's a little bit of a potpourri or smorgasbord, depending on where you're from, of musculoskeletal things. I thought I'd start off with a general introduction and then, like I mentioned, the research examples. And then if there's time, which we hope there's time unless Adam takes too long, that we will do some discussion and questions because I figure this is the one-way communication. It's always nice to have some back and forth, especially with a new area and some new folks. All right, so this is some language. I took this from the job description because this is really what attracted me to uprooting from University of Florida. I was quite comfortable there. The weather's nice there. Not really a Gator fan, but it was an okay college town. But when you look globally, there's not a lot of centers of expertise in musculoskeletal disease. There are some examples in Australia. There's a really good example in Australia at the George Institute. Also in England, Kiel does some of this in an arthritis center. But in the United States, people don't congeal around musculoskeletal disease. So the fact that Duke had identified that as a priority area was really intriguing to me because a lot of times people focus more on a particular discipline or a particular service line in medicine, and this idea that we could potentially be involved with building a center of a world excellence in musculoskeletal was really the hook. And then once you come up here and interview, you realize what a wonderful place the DCRI is and Duke Health, and you start seeing a lot of possible connections. So that was something. The language, people do actually read these, I guess, is one of the take-home messages from this slide. And then one of the things we've done with our group is starting to define how we are going to operate here as a team, as a musculoskeletal team. And we picked on the words that the DCRI and the link to those has used to help define. So this is how we hope to express our thought leadership and doing innovative research, improving delivery of patient care, and powerful ideas, and all around musculoskeletal practice. As you'll see, there's a lot of interesting things going on now with musculoskeletal disease, and there really is a good opportunity to potentially transform practice and the delivery of practice. And a lot of this is driven by chronic pain and the opioid epidemic, but that is also going to open up a lot of other avenues for how care is delivered in this area. And we're very well positioned to make an impact in there. I think we have good thought leadership here in that area. So the people that are providing this thought leadership, we thought right now our team is small, especially from the DCRI's perspective. But Janet Betker, I think, seems to be fairly well known around campus. She is someone that we will be working with and is part of the team. Chad Cook, who'll be talking, you heard introduced earlier. He is in the Division of Physical Therapy. And who else? And Adam will be talking to, also in the division. Maggie Horn, who is here, but not talking next time, right, Maggie? These are some of her interests, and you can see we do have a lot of links to the DCRI with interest in health services research and care pathways, and improving those or finding out what are the best ways to deliver those. So I think that is part of the reason why these people are in kind of the first generation of faculty that will be involved with this team. Also, Chad Mather is involved. He has involvement in the clinical research. He's also been charged in the orthopedics department with leading practice innovation, so there's going to be a lot of natural synergies between those two groups. And then finally, Corey Simon is another junior faculty in the Division of Physical Therapy who has interest in aging-related questions. And since, as we all know, our population is getting older and older, the impact of musculoskeletal disease in the aging population will be something that is of great interest. So that is the team. And then this is what we're hoping to do, and talked a little about it. We really want to follow the models and kind of become known as the place in the United States for musculoskeletal disease. I know it's a little early to state that too broadly, but in this room, that's what we'll be hoping to do in the next 5 or 10 years. One advantage is, as I mentioned, is there's not a lot of this in the U.S. One of the disadvantages is there's not a lot of this in the U.S., so we don't know exactly the models that we'll be following, but certainly we know who we're looking at internationally as our peers and our competitors. I think the other thing that this group is really interested in is that creating a robust training environment. There's a lot of room for training clinicians and training people actually with the methodological expertise in the DCRI to be interested in this content area. So the training environment is going to be really important, and doing that in a way that it encourages debate, I think, is something that we have talked about as a team that is really important to us, to not be afraid to have opposing opinions on the same team, because I think with these musculoskeletal diseases, one of the things we've learned is the management is quite complicated and can be complex. So that's kind of the buzz through of what the team is all about, and like I said, we'll have some time for some questions at the end. What we thought we would do is just show a few examples, and this is a slide that many of you may have seen. Millions of people walk through these doors. There's lots of questions about them. And many of these millions of people have pain, chronic pain, acute pain. I just call it pain. To me, they're all related. Chronic pain starts with acute pain. And this has really become people have really become aware of this nationally through the opioid epidemic. Those of us who've been studying pain, as I like to say, way before it was cool to study pain, we're aware of this issue. And in my mind, the opioid epidemic is one particular manifestation of how the healthcare system has mismanaged chronic pain. And it's a very obvious way because it's associated with mortality and addiction. But and there's going to be a lot of attention in that area, but that's really just the tip of the iceberg when you talk about managing musculoskeletal diseases. And I think that's really the acute indicator that our system isn't optimally designed to handle things like this. So, relieving pain should be a national priority. This is the IOM report, which is now the National Academies. This was in 2011. And since then, there's been the National Pain Report, and of course, the Centers for Disease Control prescription guidelines, and the American College of physicians released updated clinical practice guidelines. One of the things that is really nice is there's a ton of convergence on all these recommendations, and it's really steering people away from escalating healthcare and looking at ways to manage pain in non-pharmacologically or with different approaches. So that's why we kind of selected pain as our sampling. It's a sampler of Duke musculoskeletal research. So we're going to go through 3 examples. I am going to talk about some work that I've done, and then I'll turn this over to Chad, and we'll kind of keep going from there. All right, so precision medicine goals. This is a building where you don't have to spend much time talking about the precision medicine initiative. But really, it's this idea of customization, tailoring decisions to the individual patient, and the right patient, right time moniker. And this has not really fully been explored in musculoskeletal diseases, and especially with pain. And if you think about some of your experiences with pain management, often the recommendations are they're standard in a good way, I guess. Everybody gets kind of the same post-operative regimen or gets the same approach, but so there's no tailoring. And that has led to some problems. So one area that is ripe for the picking is this kind of precision approach. The approach that I've taken in my previous work is a lot of it, the psycho part of the biopsychosocial model is the psychological. There's a lot of work suggesting that psychological factors can predict outcomes from musculoskeletal disease, and that was something that I worked on early and have continued on. So there are some known psychological predictors of outcome. The bio part of the biopsychosocial had not been explored as much, and what folks did about 10 years ago is they started looking at genetic indicators of pain sensitivity. So what we had done is take a look at the more established psychological factors and then look at some of the genetic indicators that may increase your or someone else's ability to modulate pain. And we started looking at those in a combined predictive model. So we're looking at whether you have the genetic risk factor in combination with the psychological risk factor. The model we've looked at this in is in elective shoulder surgery, arthroscopic shoulder surgery, which if you talk to surgeons before doing the study, they say, oh, that's not a good thing to study because everyone is pain-free. And then when you do a pilot study and show them at 6 months, only 2 people out of the 50 they operated on were pain-free, then it suddenly becomes a really good model to study pain in. So what we did was we looked at 12-month outcomes, and here's our recovery criterion. So basically you had to have 0 out of 10 of a resting pain, and it had to be less than 2 out of pain when you're moving it or whatever you rated as your worst. And I'm not expecting people to be real familiar with this, but this is a stringent recovery criteria. This is, you're pretty happy with your surgery if you hit this. Most people don't expect to still have pain 12 months later, but you will. I mean, it is likely that you will. This was a strong recovery criterion. There's a lot of information on this, but all you need to know is we looked at several different genetic variations, and these are genes that had already been identified to have an impact on pain modulation or inflammatory processes. And then we looked at them in combinations with established psychological measures. We did this in a preclinical cohort where we induced shoulder pain and saw how they responded. And then we followed, and the one in bold is one particular combination that we then used to investigate the surgical outcomes. So this is kind of a classic translational approach where we identified some things that looked promising in a preclinical model, and then we're going to look at them in the postoperative model. This flow chart basically shows how we had to look, this is always depressing to look at. We had to look at about 700 people to enroll 150, and the part that's really depressing is that we had 280 that were eligible and didn't consent, or 130 that didn't consent. So, that was typical for Gainesville. A lot of people traveled a fair distance to receive their surgery at a tertiary care center, and we were asking them to come back over a year every 3 months. So maybe some of that was good, but it is a little humbling. So what we found is this particular variation a variation of the COMP gene and pain catastrophizing, which was the psychological factor, was the best predictor of the 12-month recovery. And it was actually a pretty strong predictor. Those are pretty strong hazard ratios for this field. And the survival, it's not a curve, but the survival plot shows, you can see those two risk groups really starting to deviate around 6 months. And basically the high-risk group, and this is preoperatively, had almost double the risk of not recovering at 12 months when we used that. So that was pretty interesting work. And what we're doing with that now is we're seeing if we can match treatment to this high-risk group. One of the things that is nice with the COMPT and it's an enzyme deficiency, there are some pharmaceutical pathways that people have hypothesized could work. So we're looking at that. And then with catastrophizing, there's some established behavioral interventions that can work. So that's what we're working on right now as part of a current NIH-funded grant, where we're looking at doing a 4-group design there, where we're having the personalized component and then a not personalized component to see if there's a better effect with being specific and matching the profile. This is ongoing work. We started this trial at the University of Florida, and after some discussions and thinking this through, since we had already started enrollment, we're going to finish the enrollment down there. But after a few tense moments with the NIH, I'm going to remain involved in the scientific leadership of it, which is very nice, because I'm really curious to see how this works out. If it's like most of the other studies, it won't work out the way that we're hoping, but maybe this will be different. So that is one example of looking at a better prediction of outcomes in postoperative pain, and then starting to look at whether we can develop some particular treatments to address that. So now we're going to move over to Dr. Cook, and he's going to talk about patterns of postoperative opioid use. That's the answer. Got it.
All right, it's my pleasure to actually present on the patterns and prescription of opioid use in individuals with elective hip surgery. And I'd like to talk a little bit about my journey to studying this, because it's somewhat indirect. Within the literature, there's quite a bit of information that talks about patient-level variables that predict opioid misuse or abuse over a given time. And just recently, we're starting to see studies on prescribing level variables. In other words, how they were treated, what they were prescribed, and how that's related to longer-term use. Surprisingly, though, recovery characteristics, what happens to that patient over a period of time, has really essentially hasn't been studied. It's intuitive to think that opioid prescription is related to the recovery process of the patient. And really, despite the problem that we're dealing with opioids, there's very little study in this area. And I'd like to share with you some of the research that we've done. We received a grant through the Department of Defense and Brooks Army Medical Center to actually look at data of this surgery called ephemeral acetabular impingement syndrome in their population. And the reason is because essentially the military was not paying for this out of network. They questioned whether or not the surgery was necessary, and they asked us to actually do an assessment of value first. So the purpose of this funding was actually to do an assessment of value. There's been an 8,000% increase in this particular surgery over a 10-year span, and it's actually been called the modern-day equivalent of a subacromial decompression. So many people, there's great debate on the value of this. There seems to be almost a practitioner effect, so that a really talented surgeon can have better outcomes. But at present, we have essentially grade 4 evidence on this particular surgery. Randomized trials don't exist. It's a surgery that has really blown up without the appropriate evidence to support it. So basically, the original purpose of the study was to look at cost and utilization in the military population. And surprisingly, there were over 36 visits related to this hip-related care within a 2-year period after the surgery, despite this being considered a minor surgery. And the cost was associated with this as an average of a little over $18,000. But what's really surprising is when we started to look at the drug use by the military population, and we found that there were 1,277 days worth of analgesics prescribed to this population within a 24-month period, and 77 days of opioids prescribed at 3 days or after. In other words, we eliminated the perioperative capture because we knew people received opioids for perioperative care, and we were interested more in postoperative care of opioids at that period of time. So I threw some numbers there at you. In this data set of 1,850 subjects, in which we have 12-month preoperative, 24 months postoperative data in a single payer system, which is the MDR, military health data set, a very robust data set, we found that 67.5% of individuals who received the surgery at 6 months were still on opioids. At 1 year, it was 56%. And at a year and a half, it was still 36.8%. Now, I do not think those numbers represent what we do here at Duke. I do not think of that. But one has to question this. This is pretty remarkable. The other thing we found was this. Within the MDR, they do not capture functional outcomes measures. In essence, the best we could do was look at comorbidities. So if you look at the data, we have 12 months preoperative data, 24 months postoperative data, and these are the number of comorbidities that were actually, basically they were seen for a healthcare visit related to this comorbidity. All right, so post-traumatic stress disorder, it actually increased 146% after the surgery in the 2-year period afterwards. Substance abuse increased by 55.6%. Insomnia, 100% increase. We found, and we've done a lot of work with this data set, insomnia has related to so many negative downstream effects. Cardiopulmonary diagnoses increased by 69%. Metabolic disorders by 86%. Mental health conditions by 83%. 164% increase in chronic pain diagnoses, which is also very alarming. And then lastly, orthopedic diagnoses increased by 132%. So rather than go down, which was what we hypothesized, we actually saw, in many cases, a doubling of the amount of comorbidities after this surgery. And then we started to look at the opioid use, and that wasn't the primary purpose of the grant, but we wanted to dig in a little bit deeper because we thought we were onto something here. And sure enough, when we looked at 3 or more opioids, which is recognized by a number of societies as being a critical, or essentially a prescribing element that may lead to downstream problems, that the cost related to the individuals with 3 or more opioids was markedly more than those with less than 3 opioids. And I believe here at Duke, it is common not to see 3 different unique prescriptions of opioids after this type of surgery, but in the military it was actually quite common. So quite a bit of numbers, substantially more cost, total healthcare visits, but also a substantially more hip-related healthcare costs. In other words, it was coded specifically for that surgery and the downstream cost associated with that, and visits. If we looked at patient-level factors in our modeling, in our multivariate modeling with opioid use, we find that there are many things that were related to 3 or more for the top model and 1 year or longer for opioid use. So older age was associated with more opioid use. Certainly enlisted status was associated with more opioid use, much more so than officer status. And then preoperative substance abuse, the amount of non-opioid medications used preoperatively. In fact, when we modeled this, non-opioid analgesics was a stronger predictor of long-term opioid use than preoperative opioids. So we see that as a really strong gateway transition drug. Insomnia preoperatively, mental health, all of these have been recognized before within the literature. And then health-seeking behaviors, those chronic frequent flyers that are constantly in the physician's offices asking for something, or for every little cold or sniffle or whatever, those individuals were also more inclined to use 3 or more opioids within a 24-month period after the surgery. And then at 1 year, again, it's enlisted status, females were more likely. We were surprised to find that, than males. And then non-opioid medications used preoperatively, and of course substance abuse. We're interested in looking at prescribing patterns, and I mentioned just recently data have been out that are showing this. I will say that we're one of the first to actually publish on this, and we just published about a month ago. And it's myself, Stephen George, is a senior author, and an orthopedic surgeon here at Duke, Brian Lewis, who I'm actually working with on an R01 to look at the combination of opioid use in a post-surgical population. We were interested in using modeling methods to identify the prescribing patterns that were related to downstream opioid use. We hypothesized, because in most of the treatment guidelines and recommendations, they suggest longer-term use leads to abuse or misuse. So we hypothesized that certainly some sort of longer-term use is going to be related to this abuse or misuse. But we actually found the opposite. We found that intense doses, a number of prescriptions in a short period of time within a 30-day window right after the surgery, is what actually leads to opioid misuse or abuse 1 year and up to 24 months. Now, we were the first to find this. We actually published the results, and just about a week ago, a paper came out in the New England Journal of Medicine, found a similar finding, that basically it's early intense dosage that is a bigger problem than this long-term titrated dosage. And then the CDC has also reported that too, that they really need to watch that early period after surgery and how many medications an individual is actually receiving, because that's really the vaulting point of what you're seeing for people with problems. One last thing, and because I'm a physical therapist, I have to throw this in here. And we looked at whether or not it made a difference if a person was prescribed opioids first or if they were prescribed physical therapy first, 3+ days after a person received the surgery, all things being equal. So the baseline characteristics were the same in both groups, and the only difference in the outcomes in this particular, or in the situation, is whether they received opioids first or PT first. The reason we wanted to look at that is because the CDC has recommended identifying other mechanisms for pain control, and one of the groups they actually recommend is physical therapy. So instead of opioids, consider physical therapy for pain control. In this particular case, if they received physical therapy before opioids, they essentially received about 4.65 prescriptions versus 9.71 if opioids were prescribed first. Total day supply, you can see it's almost just slightly under triple the amount. So opioids first makes that big of a difference, and then you can see the frequency differences on the amount prescribed 3 or more prescription of opioids just by the directionality of who receives care first, or what care you receive first, excuse me. And by the way, this isn't inconsistent to what we often see, is that very first type of care you receive really dictates a lot of downstream outcomes. So where does this go from here? Well, as I mentioned before, interested in patient level factors. We're definitely interested in prescribing level factors, but we're also interested in these recovery characteristics. And we feel that this needs to be modeled in a more advanced modeling method instead of the more static models that are out there, to really build in how recovery mediates some of the influence of patient level variables or prescribing level variables. And that's the next step. And now I'll hand it over to Dr. Adam Goode.
Thanks, Chad and Steve and Emily for this opportunity to speak here today. So I'm going to be talking a little bit about diagnosis and treatments for musculoskeletal conditions. It's a little bit different because I'll be talking about some ideas that we have, some proposals that we submitted, and some ongoing work. I put together a timeline here because I do wear a couple different hats between etiological, epidemiological research, and health services research. So just like Emily spoke before, I graduated from Duke here in 2005 from the physical therapy program. I then, a couple years later, started my PhD at UNC in epidemiology. In 2010, I was an AHRQ CER K-12 scholar here at Duke under Eugene O'Donnell's group, where I kind of focused and planned on focusing on health services reorganization with physical therapists as in the primary care setting. But also continued and finished my PhD in 2011, but my PhD was in biomarkers and lumbar spine osteoarthritis. So a little bit different hats that I wear there. And then, of course, last year joined the therapeutic area, MSK therapeutic area here at DCRI. So I'll talk a little bit about a project we have going on in health services, on physical therapists in the primary care, the patient-centered medical home. I'll also touch on a RO1 I submitted last year and then resubmitted just a few weeks ago on biomarkers to advance clinical phenotypes of low back pain. So the first one, the biomarker avenue, it consists of our team here at DCRI with myself and Steve and some other folks here at Duke and the Department of Orthopedic Surgery. And then we have a UNC team on there, as you'll see later, of why that is. So that's our teams for this project. Just a little bit of background about low back pain is that it is a costly and troublesome condition in the United States, as you may well know. It's very prevalent and very costly. One of the areas that I focus on is on imaging in back pain, and you may know that advanced clinical imaging may actually not do us very well, as that it can really highlight some areas that are false positives. So it tends us to lead down a road that it may not be the source of their pain, the patient's pain. And one of the reasons is that it's a static image, and metabolism of cartilage takes years to happen. And so one of the areas that I focused on was biochemical biomarkers of cartilage metabolism. And the two areas that we tend to gravitate to are intervertebral disc degeneration and facet joint osteoarthritis. And these are two structures in the spine that have been strongly linked to low back pain. Their biochemical composition is quite different. The disc is fibrocartilage, whereas the facet joint is a synovial joint, so they actually have two different compositions. And so we found that because of that, the biochemical markers can reflect those differences in those structures between the synovial joint and the fibrocartilage. This is just a figure to illustrate the example of this clinical dilemma that we have, is that low back pain is commonly sourced as a nonspecific area because there's many different factors that can lead into it. And then we have this dilemma of where to start with treatments because there's multiple different underlying sources of back pain. And so it's somewhat of a diagnosis of exclusion and treatments of an exclusion process. So this was a study I submitted last year. It stems back from our PhD work. It was resubmitted a few weeks ago, and basically looking longitudinally at whether or not biochemical markers of cartilage metabolism, pain, or inflammation in the spine can predict low back pain or progression of intervertebral disc degeneration or facet joint osteoarthritis. And then we wanted to look at different types of predictors of that degeneration or back pain. So the approach, it is a secondary data analysis project. It is capitalizing on extant data from two large cohorts conducted in the United States, the Johnston County Osteoarthritis Project at UNC and the Genetics of Generalized Osteoarthritis Study, which was at several sites, but the PI was here at Duke, Virginia Krause. What's interesting is both cohorts collected lumbar spine radiographs, specimens, serum specimens, chronic low back pain measurements in identical fashion. And the same musculoskeletal radiologist read all the x-rays from both cohorts. So there's quite a bit of consistency and overlap between the cohorts. There are some sampling differences between the two because the GOGO, or Genetics of Generalized Osteoarthritis, was siblings. They were for genetic studies. But you know, the nice thing is that we have such a consistent and large sample size to choose from here. And then both cohorts collected serum samples and urine samples for future research. So we were going to use those samples to generate new data and new markers of intervertebral disc degeneration. So just a little bit about the cohorts. The Johnston County Osteoarthritis Project's been going on for quite some time. These are the dates of follow-up. It started back in the early 1990s with an original cohort of a little over 3,000. The T1 star cohort's what I did my dissertation work out of. Our project will look at folks from T1 star, T2, and T3. So almost 20 years of follow-up that we have on those patients or participants from Johnston County. The purpose of the Johnston County project is to look at the progression of knee, hip, and spine osteoarthritis and incidence over time. Then the GOGO study, or Genetics of Generalized Osteoarthritis, it was a multi-site study. Durham was part of that, UNC was part of that, but also went into the UK, so we do have some overseas participants in that. Like I said before, all the baseline measures for knee, hip, hand, and spine osteoarthritis were done in identical fashion. And then the follow-up was 3.3 years later. It has a single follow-up to that project. So the biomarkers that we're going to look at are unique or specific to the lumbar spine. Some of these markers have only been identified in tissue samples, and we piloted them here at Duke to find them present in serum. Some of them were discovered here at Duke from the Department of Orthopedic Surgery folks, the basic scientists there. And so we're going to look at these markers as predictors of intervertebral disc degeneration of facet joint osteoarthritis with and without symptoms. So we're pretty excited about that. No one's really looked at these markers that tend to be more specific to the spine. We've looked at some that have been specific to osteoarthritis, but we know that the degenerative process in the spine is different than that of knee and hip OA. So the idea here is to phenotype these different structures in the spine, the intervertebral disc and the facet, and use these markers to create phenotypes of a mechanical group, inflammatory group, and then a pain sensitivity group, because we have measures of pressure pain threshold and pain sensitivity on all those folks. And then the idea is later to make this more clinically driven, and so that we could test the hypothesis that we could subgroup folks into these categories and then provide intervention specific for those, because that's the real dilemma, is that it's hard for us to differentiate what's the underlying cause of nonspecific low back pain, because that's why they're called nonspecific. So I switched my hats over to another project. This is more of the health services project that we recently got awarded through the CTSI Accelerator Award. And this is the integration of musculoskeletal physical therapy care in the patient-centered medical home. This is a project with our team here. Janet Becker, who is also part of our musculoskeletal team, is part of that as well. And this is something that we've been working on for 4 or 5 years at the Duke Outpatient Clinic, different clinical models of how to integrate a physical therapist for musculoskeletal care. And so we've done some observational work there, but we wanted to test a hypothesis that having a physical therapist as involved in the front line of musculoskeletal care would decrease cost and improve function as part of routine primary care. Because we know that nationwide, in primary care, there's a substantial amount of patients that enter with a musculoskeletal complaint, about 20% of all visits. And we've seen this at the Duke Outpatient Clinic a little bit higher than that. And there's also a very low referral rate to physical therapy, and we've seen that at the Duke Outpatient Center as well, about 18%. The costs are substantial for musculoskeletal care in general, over $790 billion per year, direct and indirect combined. Lots of opioid prescriptions, as Chad mentioned earlier, for musculoskeletal conditions, and a lot of ED visits for back pain, knee pain, and so forth. And so our observational study at the Duke Outpatient Center, which is about 1.5 years long, where we pretty much co-located a physical therapist there to be readily available for basically warm handoffs for treatment, we retrospectively analyzed the cost data, ED data, and prescription data, opioid prescription data, and found pretty substantial decreases for all of those when we looked at that. And so we're presenting that at Academy Health this year, but we wanted to test that a little bit more rigorously with a randomized clinical trial, because it was all observational. Obviously there's some selection issues there where patients can choose to stay on site or choose to go elsewhere. So our project was to look at a randomized clinical trial of having a patient be basically seen by a physical therapist first for evaluation and management versus a primary care physician first. And then we also wanted to look at, does it matter if, one, the physical therapist is on site versus getting a referral to go see a physical therapist versus having the integrated physical therapist where they actually act as a frontline provider. And then our aim too is to get key informants, get stakeholder feedback about these models from patients, providers, and key stakeholders. The project is now in its run-in period, so we plan to start in May or probably mid-May, and it'll include 195 patients that are referred or basically seek care to the Duke Outpatient Clinic and randomized either PT evaluation or PCP evaluation. It's a very short follow-up period, 3 months. The accelerator program is a year long, so it's a pretty quick or accelerated timeline. And at the end, we'll get some patient stakeholder feedback so we can refine that process for a larger study later. So that's an idea of what I do and wear different hats and do a little bit of epidemiological and etiological research and a little bit of health services research, and then maybe one day I'll combine those together and may see biomarkers in health services and musculoskeletal care. So I'll turn it back to Steve so he can summarize.
Thank you. Thanks. All right. So it is a short summary because, like we said, we want to leave some time for questions and/or discussion. But I wanted to, let you know that we have several scientific areas that you're interested in, and I think several of those were expressed. The focus was on pain, that first one, predicting and preventing the transition. But I think you can see other parts in these, and I guess the point is, these are the areas that we feel most confident in, that we have some strength in, that we feel like we can be competitive in. And I think it's helpful, again, as we're kind of establishing our identity here, that people understand those are the things that we're very comfortable with. And I think you kind of got a flavor from that of what the scope of the work that we're doing and the type of training. And then, right now, I think just a little bit of kind of how we're structured. Right now, the center of this is really, as you can see, orthopedic surgery, and with a heavy emphasis in the division of physical therapy, which is within orthopedic surgery. And obviously the DCRI, but the other thing that was very attractive to me was the center is not supposed to hold in this case. We're supposed to spread and really have it be university-wide representation. And even outside of the medical center, and also obviously we will be continuing collaborating outside of Duke, and you can see that Chad has a great military collaborator that was able to provide some access and collaborate on the opioid questions. Adam has established with that other school, the university, what's the UNC, the other blue or whatever, which. And I trained at West Virginia in Pitt, so I kind of know how that works. For those of you who aren't familiar with that, that's a different type of rivalry, but kind of the same feeling. And one of our early grant submissions already involved the Durham VA, which was great, in a large pragmatic trial submission. So, I think we're off to a pretty good start. We will find out. When people ask me, how are things going, I always say, I'll tell you in 3 to 5 years, because I think it'll be very clear. But the early indicators are very, very positive. So. And last, again, we're trying to establish our identity. So if you are a Twitter type person, you could have read about Chad's paper through the Duke MSK, and we've also talked to the DCRI folks and the orthopedics folks. So we try to get things out across 3 different channels. But this is our Twitter handle for now, and one of my resolutions now that the grant is submitted to be more active on this, because I'm a Luddite with social media, so I actually have to get Twitter on the app before I can do some of this stuff. But we have been doing this as a team, and it's, like I said, a way to establish our identity. So with that, I'd love to open it up to some questions. I don't know if is it okay to stand, or I know I've seen you do it a couple different ways. All right. Well, and yeah, come on up, Adam and Chad, because I'm sure someone may have yes.
So thanks. That was terrific, and good to see what you all are doing. It's exciting, and you probably know, including through Janet, who does a lot of this work with stroke, that rehabilitation, which I guess is a kind of physical therapy, right?
Yes.
Is something that's really important for a lot of the other chronic diseases we deal with, including heart disease. There was this interesting study from the Amazon that got a lot of press this week, where this community gets no atherosclerosis in this Amazon tribe. And I have no idea whether this is true or not, but they ascribed it to the fact that they walk 17,000 steps a day. I have no, sounds like that's entirely speculative, but nonetheless provocative.
Right.
But I would think that there should be a good opportunity for us to think how we can apply some of what you're doing to, kind of similar themes in management of some of the chronic diseases.
Definitely, I think I think I agree. There's a lot of convergence in the methods and the approaches that will be used to manage, the chronic diseases, and including.
I'd also just point out, and this, I think you all acknowledge this, but just to reiterate it, that the observations that you make, like, whether you get referred first to rehab or to narcotics or something, is interesting, but it's so confounded as to be, I would suggest, simply provocative and hypothesis generating, but of very little value in actually reliably determining the effect of different approaches. So I think what you're doing now, getting into the randomized trial activity, is obviously a crucial next step.
Definitely. You guys have any comments on that? I know you, with the PT First model, there's any experiences with that?
Yeah, there's quite a bit of evidence that the provider you see first can really influence downstream costs and care. It's a process research. So I think I'm with you there. One little study that says this or that isn't going to say anything, but I definitely think that when there are trends, we might want to start looking at how care is managed across the system. And that involves trials, it involves observational work, involves everything. But I agree.
But a big study, I would suggest that a big study has just as much of a likelihood of being unreliable, just with narrower confidence intervals. So it's even worse to have a big observational study that's confounded than a small one, in some ways. We do this a lot, right? This is our lives. But these big, we do studies with data sets with millions of people, and then we come up with these really precise observations that have huge p-values, but have the same issues with potentially being confounded. I just, all I'm doing is supporting your
Yeah, no, I think, and actually,
extending the research to more rigorous
yeah.
Approaches that can actually more reliably determine cause and effect, which means randomization.
Definitely. Yeah.
Yeah, again, thanks for doing this, and I'm really excited to see us moving in this direction and you guys leading it. I think, I'll just echo what Chris said, that I think there's this huge push, certainly across cardiovascular, of trying to get people moving more. And as you think about, you guys are right now, I think appropriately, more focused on acute and more post-surgical and post-pain, but there's all this stuff that I think there'll be great opportunities for collaborating with other groups, and we talked some about thinking about how to start measuring just physical activity on subsequent downstream musculoskeletal outcomes, and how can we collect that stuff better in the big cardiovascular trials we do, and so that we can help inform the field.
Definitely. Yes.
So 2 questions. The first is, Adam, you finished your PhD in Epi in 4 years, which some might say is extremely accelerated relative to others who took longer. So what's your secret? And the second question is for Dr. George. So when you were building the predictive model with the catastrophizing and then the genetic markers, and it sounded like those were sort of treated as independent. And I'm curious about any existing knowledge on whether there are connections between the genetic markers and the psychological manifestations that might lead to more downstream pain perception, and sort of what, if you were to sort of draw out traditional epi-DAG, if it's more mechanistic with psychosocial factors as on the causal pathway, so to speak, or if they really are truly independent and can be treated as such.
Yeah, go ahead. What's your secret?
Oh, my secret, I think that, I don't know if this is a secret, because I think that all PhD students plead with their advisor, but I had a great, Steve Marshall and Tim Carey were, I begged them, so that was basically the secret. It's not really a secret.
Yeah. They wanted to get rid of you? Is that the secret? Yeah. Actually, that's a great question, because it is an interaction between the two. So when we do the subgrouping, and some of the early work has shown that the interaction term, when you build the model, with the main effects and add the interaction, and it's really driven actually by needing, having both. So there's equal risk if you have one risk factor or no risk factors. We see the increased risk with both risk factors. And when we've looked at whether, and those are, so when we look at the genetic variation and see if there's differences in psychological distress based on the variation, they aren't typically, sometimes what we'll see in the different cohorts is depressive symptoms will be different, and that's kind of expected with what that gene, because COMPT it's a sensitive marker, but it's not very specific because it's been studied in a lot of neurological diseases and Parkinson's, and pain is now basically, conceptualized as a neurological disease, chronic pain, so that's not that surprising. So I don't know if that directly answers it, but when in this study we had already shown the interactive effects, so we were looking at the higher catastrophizing scores with the genetic variation as a subgroup.
So thinking about the clinical application, it sounds like it'd have to be multi-level type, use the genetic markers for identification and then potential direct interventions on the psycho.
Correct, yeah, and that's what we're hoping to find in the preclinical study. Again, do we need to do both, or if you just get one that matches? Because we're only recruiting, this was a big debate, but I guess we chose right because they decided to continue the work, the funding of the work. We're only recruiting the high-risk people into the study, so we can't truly see, what the low-risk people would respond. So, our effects are a little bit limited, but we decided we were already going to enroll 440, so we also wanted to make sure. So at the very least, we'll be able to say for a high-risk person, does having both parts matched better than having nothing matched? I can't tell you what it'll do in the low-risk person. But in a way, those people are the ones that have a good prognosis, so the decision for treatment isn't nearly as important.
We didn't talk much about your strategies around trainees. Who are you? I mean, is it ortho surgery residents? Is it physical therapy? Is it both?
It's everything. I mean, I really think one of the things I've enjoyed, I've been, on committees for psychologists, biostatisticians. I think to me, it's either finding people who are familiar with the content and want to improve their analysis, or that part, the methodological part, or finding my hope, and I've talked to Leslie about this a little bit, is to as the training element of population health grows, to find some people that have those methods and analytical expertise, but want to learn a little bit more about the content. I think that's something we can offer as a clinical. I think right now we'll focus on postdoctoral training because we don't have established degrees, but again, longer term, as PhD programs evolve, and we have some opportunities to do work in populations, I think the musculoskeletal health will be a nice concentration area to recruit, pre-doctoral students into.
Are there research requirements in either the PT program or the ortho program, or both?
Both, and we need to figure out. And Chad had, the DPT program does a really nice job, but haven't done it in combination with something like the DCRI, and that was something that we would love to have. We're meeting with some other folks who have data that are granular enough to ask musculoskeletal questions that I wouldn't mind there being, like a fellowship option where if somebody wants to spend 2 years of a focused, it would be a different model than that is established here for the cardiologist, but it would be a chance, post your clinical degree to come here and get some really good experience, and we're exploring that too. So we're kind of looking at all avenues and seeing what's gonna fit. Yeah. Yes.
Thanks. First of all, I'm now following at Duke. And
thank you.
Now follower. Second comment is with the catastrophizing. I was wondering if you could talk more about what exactly is that measuring? Is that just kind of catastrophizing life events in general, stressful life events, or is it more pertinent to their pain? And then do you treat that pre or post-op, or?
Yeah, good question. So it's not there's several catastrophizing scales. It sounds like you know a little bit about catastrophizing the construct. We use the pain catastrophizing scale, so it is specific to their beliefs about pain, and really there's several different components of that. One is rumination, so people who catastrophize tend to repeat, so it is repeating that this hurts a lot. I think it's going to get worse. I don't think there's anything anybody can do. Pessimism is another part of that. So it kind of captures all those. And some people use the subscales. They're so highly correlated, we just use the entire scale. So then the interventions are very focused on the pain catastrophizing. It does bring up a good point indirectly that depression and pain catastrophizing tend to be highly correlated. So there probably are a subset of people, that may benefit from maybe a broader type of psychological intervention, and we'd like to work back to that. But believe it or not, it's been enough effort to get people in like an orthopedic setting or a musculoskeletal setting to be open to this idea that even pain catastrophizing could matter. But there's just a sheer volume of literature, especially in chronic pain, about the relevance of things like catastrophizing and fear and anxiety that you see management models being responsive to that. But most of them are pain specific.
Thank you.
No, thank you. Yeah, thank you.